the focus that I'm going to have for us this evening really is on advanced care planning. My hope is, though, that by the end of the discussion, you'll actually be using some different terminology. So that's my goal, is to actually get you to change your thinking and your wording around the specific phrase of advanced care planning. But the specific objectives that I want to do, want to make sure that we achieve, is focusing in on the long-term care sector and what are the challenges as it relates to what we think of as advanced care planning. We're going to talk about terminology, which I sort of alluded to, and talk about an approach that really optimizes the strengths of teams. I think that's one of the biggest gaps or almost failures of advanced care planning currently, is when we don't optimally utilize the skills of our interprofessional team members. And so really going to get you all to be thinking about how we can actually impact care by ensuring that we're utilizing all of the skill sets of all the folks that are on our teams. So just to start with some of the specifics right off the bat, specific challenges for long-term care as it relates to, I'm gonna sort of broaden things a little bit and include kind of decision-making, advanced care planning. Some of the unique challenges or challenges that are fairly specific to long-term care is that many of the residents have already lost capacity, often at the time of admission. And I tried to change all of the words patients to residents throughout my presentation. And of course, on my first slide, I've missed that. So my apologies. But I think the point of this is really to say that decision-making capacity is often lost at the time that long-term care settings are just getting to know people. So that makes it a little bit tricky. And what that means is that it likely is often sort of too late for what we consider advanced care planning conversations. And we're not really yet at the point of having goals of care conversations either. And the reality is that things happen in the middle of the night. People get really sick, and nursing staff and staffing clinicians need to have a sense of what to do and who to call and what's the approach that we need to be thinking about. I'm going to be a little bit provocative here and sort of say that the reliance for many of the long-term care facilities throughout Ontario, throughout Canada, throughout North America, actually, the reliance on level of care forms is quite consistent and persistent. But I would propose to you that level of care forms actually might not be helpful and might not be compliant with Ontario law, and in fact aren't compliant with Ontario law. And so if that's the case, what do we actually do? When I say level of care forms, just for folks to know, I mean sort of the tick boxes that tell you about a person's code status, tell you about various other kind of treatment decisions that people would want, whether or not they would want to be transferred to hospital, things like that. So that's what I mean by level of care forms. And right off the bat, I'm going to be provocative and say that they actually are not Ontario compliant with the law, but more importantly, they're not necessarily helpful as far as the care that we're providing our residents. I'm going to challenge you to think about, where are some areas for practice improvement in this whole sort of sphere around advanced care planning and decision making. And I would say that the first area of practice improvement that is true for every setting is be clear on what kind of conversation you're having, and that's really what we're going to get into the details of tonight. Integrating person-centered conversations into care, and we'll get more into what I mean about that, and then recognize the problem with level of care forms. So as I will explain why they are problematic as we go on. Okay. So what I want to start with is a task, and you guys are going to be active in this task, and it'll require your phone or a computer wherever you're sitting at. But I'm gonna ask a what would you do type question, and for you to participate, I'm hoping that you can pull out your phone or your computer and go to slido.com, slido.com, put that into your browser or to your phone, just type it directly into your phone. And what will come up is what you're supposed to. It asks you to enter in the event code, and I put it in for tonight's event, dining to learn, with the decapitalized and all one word. So dining to learn as the event code at slido.com. I'll leave this up just for a second. Jeremy, maybe you can let me know if you are get in there, no problem.
Okay.
Were you able to, Carl?
I just went to slido.com there and I put that in. It's kind of at the top there. There was a little place where you could just write dining to learn, and now I'm
Okay.
in the Q&A section there.
Thank you. All right. So this is the scenario, and it is what would you do if you suffered a life-threatening injury and you were offered a surgery that could save your life? However, with the surgery, there's an 80% chance of paralysis of both upper and lower limbs. And the question I have for you is, would you have the surgery? So again, you suffer a life-threatening injury, you're offered a surgery that could save your life. With the surgery, there's an 80% chance of paralysis. Would you have the surgery? So if you look on Slido right now, there's a slot for yes and a slot for no. So go ahead and enter whether or not you would have the surgery. This will also tell us how many folks are paying attention, because how many responses and how many folks are technically savvy and able to get in there. So we've got about 22 responses so far, and pretty close to 50-50. Okay, I'm going to go on to the next question. There's one more scenario, and it is, again, what would you do? If you had a debilitating motor condition and you're offered a medication that allows most patients to function independently, however, most patients also experience a 30% reduction in cognitive function, would you take the medication? So again, debilitating motor condition, but you're offered a medication that allows most people functional independence, but most people also get a 30% reduction in their cognition with this medication. Would you take the medication? Thanks, Carl. See if we'll wait for 25 for sure. Almost 50-50 again, and I wonder if it's the same people. So thanks to everyone who participated. And obviously with these kinds of questions, there's no right or wrong. There's no right answer or wrong answer. But I want you to think for a second about how you arrived at the decisions, right? So I'm not sure how many folks entirely are participating, and I'm really super grateful for those that did. But for 30 people, there was something that went through your mind, right? And how did you arrive at that actual decision? And what I would sort of propose is that what these words mean. If you entered a response and fairly quickly, you were able to arrive at a decision fairly quickly, you know what the words paralysis and the words loss of cognition actually mean. The reality is that 99.99% of people in this world do not know what these words mean. And so that's one source of information that helped you to make a decision. All right. These words, paralysis, and what was the loss of cognition, paralysis and loss of cognition, you get a sense of what life would look like, right? You have an image. That's what kind of conjures up in your mind as an image. What you also have is a sense or an image of what would be acceptable to you or what would not be tolerable for you. And it's these two streams of, and sorry, before I get into that, most people actually haven't thought about what they would consider acceptable or unacceptable, tolerable or intolerable in terms of life in the future, what that might look like, right? It's not something that we necessarily think about very often. But for decision, an effective decision to be made, which each of the 30 of you did, you need both pieces of information, right? You need a sense of what life would look like, an image of what what life would look like, whether or not you had the medication, whether or not you had the surgery, and you have this inherent sense of what's acceptable or not to you. You need both pieces of information in order to arrive at a decision. And really, it comes down to what you most value in life, right? That really drives the underlying decision. So I would propose to you that for a resident decision, any decision that a person is making about their healthcare, that they also need these two streams of information, right? They need information about illnesses, they need information about treatments, and in a way that they're able to have a sense of what life would look like, in the same way that you were immediately able to conjure up an image around paralysis and loss of cognition. The other stream of information that they need is about themselves, what's important to them, why it's important, which is essentially their values and goals. Just like your decisions, both pieces of information and prioritized values and goals are needed for decision making to be effective. So, that's I do this little exercise to sort of demonstrate for you how straightforward it can be for us to make decisions, but what a significant disadvantage most people are, because they don't they lack an understanding of what life would look like, these images, or we've not talked about sort of what's important and why it's important to them to the future. So I just wanted to kind of level set around the process of decision making and give you some concrete examples of what that means and what's involved in it. And so, the reason why this is a topic, advanced care planning, and why I'm speaking with you about this this evening, is that this little scenario here is the crux of the problem, the crux of the challenges that we have with advanced care planning. And so this is Joe on the right and his wife, Sandy. And Joe says to Sandy, one day, his brother's in the hospital. Joe's brother's in the hospital. He's in ICU and he's on a ventilator. And Joe, at the end of a 3 weeks of seeing his brother every day, he says to Sandy, Sandy, I don't want to be hooked up to machines. Make sure I'm never hooked up to machines. Well, cut to 3 years later, and Joe's sent to the Emerge with a pneumonia. He has developed in the interim some dementia moderate to severe cognitive impairment, and he's got a delirium because of the pneumonia, and he lacks capacity to make a decision around the approach to managing his pneumonia. And the Emerge doctor turns to Sandy and says to her, Joe will only need to be on the machine for a few days. So Sandy's in this position where 3 years ago, Joe said to her, don't ever put me on machines. And this Emerge doc says, we only need to put him on for 3 days, right? Sandy doesn't know what to do. And on one hand, she's disrespecting what she understood to be Joe's wishes around this. And on another hand, it seems like a few days might be okay, and he might actually be grateful for that. And so what's problematic about this is that it's very much a focus on treatments. It's a focus on the machine. Substitute decision makers often have difficulty applying information about specific preferences. And this is a little bit of a snapshot into what's challenging about level of care forms. What are level of care forms? They're very specific treatments, right? And so this is just to sort of begin to sort of say that when we talk about treatments and in a future context, it's very difficult for substitute decision makers to actually apply that information. And this is just an example why. So I'm going to pause for a minute here on the advanced care planning piece and focus a little bit on substitute decision making for a moment, because that tends to be a really big area of misconception and of questions, right? So before we get to SDMs, I want to just talk about capacity. And what is decision-making capacity? What's required for someone to have decision-making capacity about a specific treatment or care that's being offered? So capacity requires a person to understand the information that's relevant to making a specific decision and appreciate the reasonably foreseeable consequences of a decision or of a lack of decision. So, it's the level of appreciation that's required really is quite nuanced, and the person does need to have a full and complete appreciation for what would happen if they did make the decision and what would happen if they did not make the decision. And so then coming to the substitute decision maker, this is in Ontario, our substitute decision making hierarchy. All right. And I'm just going to pause for a moment here and walk you through the hierarchy. And there tends to be questions that come up when I get to the next slide around misconceptions and clarifications. So let me just get through this and then we can start to get into the questions. Okay. So The green is what's called the automatic family member substitute decision maker group. Okay, so um, every person in Ontario, by law, by the Healthcare Consent Act, has a substitute decision maker already. And this is the guide as to who that is. For most people who have not had conversations or have not made any sort of action, the green applies to them. So if you have a spouse or a partner, that is, and there's very specific definitions of what that actually, what's required to be considered a spouse or a partner. That is the highest ranking automatic substitute decision maker family member, and then it goes down to sibling, to parents or children, parents with right of access, siblings, and any other relative. Above the green, though, you can see these three categories of legally appointed substitute decision makers. So we've heard the words power of attorney, right? And what power of attorney means is that an individual has gone through the process of identifying a person that they would like to be their substitute decision maker for a time when if they lose capacity, and that person is called their attorney for personal care. And you can see by this hierarchy that that person has a higher status than any of the family members. So if I'm married and I have 2 kids and I have 3 brothers, but I want my friend Jack to be my substitute decision maker, I appoint Jack as my attorney for personal care, and Jack trumps all other people for being to be my substitute decision maker. So just some common misconceptions around this is that attorney for finance and property is not the same as attorney for personal care. All right. So these are 2 very different concepts. They're 2 very different criteria for when they would be enacted and when they become relevant in a person's life. And we're talking about attorney for personal care. An attorney for personal care is a substitute decision maker, right? So each of those categories, the yellow, the green, they were one row of an example of a substitute decision maker. So a person at power of attorney is actually a substitute decision maker. Capacity for decisions can fluctuate and needs to be assessed at the time a decision needs to be made. And the last kind of common misconception before I kind of open it up to questions is that a resident might have capacity for some decisions, but not for others. So the example that my colleague Nadia Cardona often gives is a young child, a 5-year-old who's broken their arm, and they wouldn't have capacity to make a decision about whether or not a cast goes on because they couldn't appreciate the future consequences, right, of not having a cast. But they could decide what sticker they're going to have on the cast, right, and or what color they want the cast. So that's sort of not to be flippant, but there are degrees of complexity around decision making, and a person can have capacity at the same moment, have capacity to make one kind of decision or one specific decision, but not another one. So capacity is very decision specific and needs to be assessed at the time that a decision actually needs to be made. Okay, so maybe I'll pause there and just check in to see if there's questions.
Yeah, there's one in the chat box, Jeff, if you'd like me to read it out to you.
Yeah. Yeah, please go ahead.
Okay. So the question is asking who determines if a resident has capacity to make their own decisions or if an SDM is required.
So it's a great question. What I'll do is I'll just go back actually. So the person who is offering the treatment or the care, the specific treatment or the specific care element is the person that determines whether or not the resident has capacity. So if I'm a physician or a nurse practitioner and I'm offering antibiotics for pneumonia, then it's me who would assess the resident's capacity to make a decision about managing the pneumonia. If there's a decision that if a recreation therapist is checking in with a patient, a resident, to determine their desire or willingness to participate in an activity for that day, and whether or not they have the capacity to make that decision or that care element, it would be up to the recreational therapist to assess their capacity to make that decision. So it's the clinician who is offering the treatment or the care that actually makes that assessment.
Yeah, thanks, Jeff. That helps a lot. There's been an additional question further to that,
Sure.
asking what happens if one healthcare provider thinks the resident has capacity, but another healthcare provider does not agree.
So it comes down to how many providers are offering a specific treatment or care elements, right? So if there are two, there can be different opinions amongst the team as to whether or not a person has capacity for a specific decision, but it is the individual, the clinician who's offering the treatment or the care that ultimately has the responsibility. And if there's more than one person that's offering the same care, that it'd be a bit tricky to understand sort of what the scenario is. I'm wondering maybe something like an occupational therapist and occupational therapy assistant who are or have both are having a session with the resident. Perhaps that might be a scenario where they could have differing. And I think in that case, it would just be through discussion and dialogue that you would sort of arrive at a conclusion.
Okay. Yeah, so there was some clarification from the person who asked the question. They've said they were thinking in a long-term care home if there was a rec therapist and an OT, for instance, in the long-term care home.
And it's weird that's not a planted question.
Yeah.
That's pure coincidence that, or pure luck that happened to
Absolutely.
guess the two professions. So again, I would say that probably the treatments or the care elements that the rec therapist is offering would differ from the treatment and care elements that the OT would be offering to the person. So again, it tells you how very, very specific decision capacity is decision specific. It's all the way down to the very specific decisions that would be made by specific professions.
Perfect. Thank you, Jeff.
Okay. If there's other questions as we go along about SDMs, please, anyone who's watching, feel comfortable chiming in, because there's it's really complex and really tricky stuff. And so as we go along, if there's questions that do come up, don't hesitate, anyone. So I've kind of already gone through the common misconceptions. Okay, so we're going to go switch gears and go back to sort of the advanced care planning, right? And I was sort of started off by saying, I'm going to shift a little bit around the language, and I want to talk about get into a little bit of the science here and the evidence. So in 2021, in JAMA, the Journal of the American Medical Association, there was an editorial, a viewpoint that was written by three of my sort of world-renowned palliative care colleagues. Sean and Diane and Bob are really quite known around the world and are very influential, I would say, in palliative care contexts, anyways, in palliative care circles. And they wrote a viewpoint around that was titled "What's Wrong with Advanced Care Planning?" And the conclusion that they arrived at, or their whole point of their article, was to make the claim that advanced care planning does not improve end of life care. And actually, they were even more broad than that. I would say they said advanced care planning doesn't improve care at all, and that documentation of advanced care planning does not serve as a reliable and valid indicator of an end of life discussion. So their recommendation was that we stop actually advanced care planning, and that we stop advocacy for promoting advanced care planning. And you can imagine this sort of caused a great deal of, at least again, with palliative care nerds that are interested in stuff like this, like me, was all over this. But it was quite jarring for many countries that are looking at national advanced care planning strategies, for example, when three such influential individuals had this viewpoint. And when you read this piece really carefully and you look at the definition that they used of advanced care planning, I've put it in quotes here, that advanced care planning should ensure that people share their values, goals, and preferences regarding future potential medical care decisions. And you can see that I've highlighted that word preferences there, because to me, the word preferences kind of hints a little bit at preferences for specific treatments. But when we go on into this viewpoint, they actually identify the 8 steps for a successful advanced care planning process. And the very first step that they identify is that a patient can articulate their values and goals and identify which treatments would align with those goals in a hypothetical future scenario, which is kind of the equivalent of Joe saying to Sandy, don't put me on machines. And Sandy, a few years later, not knowing what to do with that information. So Sean and Diane and Bob, they took a very treatment-centered approach to defining advanced care planning, and they're absolutely right. That advanced directive treatment-focused approach is not effective, does not improve care. There's no argument about advanced directives, which is what we're talking about with this. When I say level of care forms, when I say advanced directives, I mean the ticky box of treatments that are often used around North America. We know that those are not impactful in terms of the care that a person receives. So when you really dug deep into this viewpoint, it was kind of like, well, duh, like, when you define it in this way, it is problematic. The problem is that they weren't clear about an alternative. They only offered advanced care planning as this advanced directive. And so, that's really what, again, tonight is about, is to kind of hopefully demystify this a little bit, simplify this a little bit for people, and come up with some concrete approaches moving forward. Because the reality is that despite 30 years now of sustained efforts and improvement, quality improvement projects and efforts around serious illness communication, and with serious illness communication, I mean advanced care planning, goals of care discussion. Despite 30 years of efforts, there have not really been sustained improvements in care, improvements in experiences of residents. We've not achieved that. So what are we doing wrong? What do we need to be doing different? Okay, so here's part of the problem. Now, the second kind of objective that I talked to you about was clarifying terminology, right? On the left here, I've outlined for you, already I've used myself all of these terms, pretty much all of these terms in this discussion this evening. And there's an unbelievable amount of diversity and inconsistency in how advanced care planning, goals of care discussions, DNR, DNI, SDM, power of attorney, advanced directives, there's an unbelievable amount of inconsistency in how these things are defined and how they're described. And it's really problematic. It's one of the reasons why we're not able to make sustained improvements. And there's a ton of communication skills training programs that have been developed that then use their own terms. And the example being the serious illness care program with the serious illness conversation guide, which has helped in some ways, but in other ways has actually just added yet another term and made things a little bit more confused in some ways. So, we're at this kind of crossroads where we've got all of this terminology, all of these programs. There's no agreement on the definitions of these things. There isn't agreement on what the outcomes of these conversations should be, which is ends up being obstacles to individuals, to teams, to institutions, and to researchers when we try to apply them. What does it mean to advance care plan? What is the outcome of goals of care discussion? There's such great diversity in all of this, and then professional bodies are using these inconsistent definitions to develop guidelines, and then perpetuating these misconceptions. So, for somebody that spent kind of 20 years of my career thinking about this, a year or two ago, it just sort of got to the point where we just really need to simplify this for people. We really need to break this down. Clinicians at the end of the day are not sure whether or not they should be talking about treatments, values, wishes, advanced decisions. Can an advanced decision be made? And then most importantly, what's my role in all of this, right? As a staff person, as a clinician person working in the long-term care setting, what's my actual role? And so what I'm going to do is walk you through a Sandy and Joe example again, and highlight how we can reframe this for folks and simplify things and make your days hopefully a little bit easier. So I've already introduced you to Joe and Sandy, and some more details about Joe. So he had a heart attack when he was 67 and had bypass surgery. He's had 2 admissions in the past few years for heart failure, and he was recently diagnosed with moderate cognitive impairment. So he is still at home. He's not in long-term care yet, but this is his illness sort of timeline. So at the time that he's, if you think of sort of over time, he's got hospital admissions, he's got visits to his cardiologist, he's got visits to his family physician, he's maybe got visits to his geriatrician, and all of these are sort of sandwiched over time, right? Each of these, there's conversations or communication about Joe's serious illness, about his heart failure, about his dementia. Communication can really occur at any point along this timeline with any clinician in any setting. And that's what I'm going to propose to you guys, and as you sort of clarify what your role might be. So how we think about it is that, there's points along this illness trajectory where decisions are going to be made, right? So there's many that have been made already for Joe, and there's many more that are going to be made. Some will be made by Joe, some will be made by Sandy. But there's many more to come in as we think about the future for Joe. What I want you to begin to think about is what happens in between decisions, right? So there's all of this time in between decisions, and what I want you to think about this time as preparing, right? So this whole mess of serious illness communication, this whole mess of advanced care planning, goals of care discussions, level of care, really simplifies and boils down to preparing or deciding. So what do I mean about preparing? Well, if we think about both residents, there's my second patient that I kept in there should have resident, but residents and substitute decision makers, if they were adequately prepared, there would be an understanding of the substitute decision-making role, right? The SDM would understand their role. They both would understand Joe's illnesses, and they would have explored what's important to Joe, right? If he's well enough, they would have explored that. That's what a prepared resident and a prepared SDM actually looks like, right? So there's an understanding of the SDM roles, or understanding of the illness, and what matters has been explored. So, instead of trying to figure out whether it's advanced care planning or the elements of each of these, we very simply ask ourselves whether or not a treatment or care decision is needed. And if so, then you're having a deciding conversation. And every other interaction with a person is an opportunity for preparing. And so it really is guiding on what needs to be done, right? So this isn't necessarily replacing advanced care planning goals of care discussion. It's just kind of hovering above it and saying, okay, let's just make things really simple for people. Are you preparing or are you deciding? We all have a role when it comes to preparing people for the future, right? So for example, heart failure, you don't need to understand the specifics or know the specifics of prognosis around heart failure. This is the trajectory of a heart failure, right? Where there's exacerbations of a person does unwell, then they improve, then they do unwell again, and then they improve. This is the trajectory of dementia. There's the slow over time. We know this. This is the image of life, right? That you were able to apply when you made decisions about surgery and medication. This is the information that patients and their SDMs need to actually be prepared for the future. So this is what we're talking about in terms of the kinds of information that would be helpful to people. All right. So this is how this kind of hovers above advanced care planning and goals of care discussion. And so, I put this up here because coming back to the long-term care setting is where things get a little tricky. But I wanted to lay the foundation for preparing or deciding being a very simple approach to to guide kind of whatever conversation we're having with a person, regardless of our role, regardless of the setting, and regardless of where a person is on the trajectory. And what I want to point out is that when we think about preparing, there are going to be sort of 3 different contexts for preparing, right? So there is advanced care planning when a person is healthy and capable. There's advanced care planning for a person who is capable but has a serious illness. And for folks who are, which is probably, the majority in the long-term care sector, if they are not, they're not facing a decision, but they no longer able to, if we're able to say sort of broadly that they're no longer able to participate in advanced care planning because their cognition, for example, then it really becomes about preparing the substitute decision maker for future decision making, which isn't advanced care planning. So that's why really thinking about this as you're either preparing the person or you're preparing the SDM is the bottom line.
Jeff, can I just jump in with a quick question from the chat box there? Because I think it makes sense. The question is, should we be having these preparing ACP conversations in long-term care?
Oh, yeah, 100%. 100%. But we'll talk about what that actually means and what that looks like, right? So what maybe I'll start with this. My sense is that there are many cues that that residents or their substitute decision makers are giving us that we notice and aren't sure what to do with, or we don't notice. And by cues, I mean statements like, I don't know how much more of this I can take. Statements like, it's so hard to see Jack like this. I know that he would so not want this. Those are moments that can are much more amenable to shifting to a preparing kind of conversation than a big sit down team meeting to have an advanced care planning conversation with the SDM. I think that there are many of these little moments that happen often over time that are cues that tell us that a person is ready to talk about all of this stuff. And I think that in a person's home, in the long-term care, when they're there, there's a comfort level that they have with so many of the staff that there's an intimacy, a familiarity. And I think that there's a lot of times that these cues are being stated, and it's for us to pick up on them and help acknowledge them as a person's ready to actually talk about this a little bit more. I can see there's a few questions, and I wanted if there is any follow-ups from that, Tara.
There are no real specific follow-ups. There's
Okay.
one question, but I'm not sure if you want to address it now. It's asking what happens if there are multiple substitute decision makers that are.
Sure. Yeah. No, we can do that for sure. So if there are multiple decision makers on the same level, right? So if you've got if I'm not married and I don't have children, but I have 3 siblings, as an example, right? And the 3 siblings are my substitute decision makers. All 3 of them, if I've not appointed either one of them or 2 of them or somebody else a power of attorney, then all 3 of them are my automatic substitute decision makers. And if I lose capacity for a specific decision, they must agree, all 3 of them, on what the decision is. That's what their responsibility as an SDM actually is they must come to an agreement. And sometimes that can be tricky, but it's the only way to keep the PG&T out of the equation is for folks that are on the same level to arrive at a decision together.
Yeah, thanks for that, Jeff. And I don't know if you suggest to people if you foresee that that's not going to go well, they really need to consider preparing a power of attorney.
Yes, yeah, exactly my point, right? So if there is, that's a wonderful point in that part of preparing, right? To go back to what we were talking about before is that the SDM knows that they're the SDM. They understand the role. All of them understand the role, and they understand the underlying illness, right? So it's actually a really nice segue in that if there is the potential for conflict or the potential for the SDMs to not reflect a person's wishes, if they're in fact imposing their own wishes as opposed to kind of reflecting a person's wishes, and if there's a chance for conflict around that, you're going to know ahead of time if there's a chance for conflict. Let's be honest, right? And so appointing either any one of them or somebody else as your power of attorney is just responsible.
Thank you for that. And we also have a question looking for clarification of the difference between the SDM and the POA.
Okay. So a POA is is one kind of SDM, right? So the POA was the middle row of the yellow, right, above the green. And so each row is an example of an SDM. And a POA is one example. The power of attorney is the trumps all other automatic SDMs that are come up in the hierarchy. So a power of attorney is a substitute decision maker, an example of one type of substitute decision maker.
Would it be fair, Jeff, to say, and this is a personal thing, when I am doing some work with long-term care homes, I often say that the power of attorney is a piece of paper in which we name a substitute decision maker. Is that?
That's exactly right. Yeah. Yeah, that's perfect and it doesn't require a lawyer. That's the other thing, just to point out for folks, is that to identify the a power of attorney, you just need it to be witnessed by somebody who's saying that it's you signing your signature there. It does not require a lawyer, and it is the piece of paper that communicates to the rest of the world who you want to be making decisions for you if you lack capacity.
So we have one more question.
Okay. Yeah.
Quite specific. So it is, do children's spouses fall into the automatic STM category of children, or is it only direct children, for example?
Spouses' children? Is it spouses' children?
No, I think it's children's spouses, if I understand correctly.
Oh, okay. Do children,
so
now, because when you said the word children, I immediately went to like a 6-year-old, and then when you said spouses, I was like, wait a minute, the 6-year-old can have spouse. So,
yeah,
ask me again now that I
yeah,
have.
let's look at it again. Okay. So do children's spouses fall into the automatic STM category of children, or is it only direct children? For example, only child has died, but spouse and grandchildren are still alive.
If spouse and grandchildren are still alive, then spouse is the SDM, because spouse is higher than anyone, if I'm understanding correctly.
Yeah, I think they're saying that, I'm imagining it's like an older person and they have an only child who has died. So
and then
but the only child's spouse is still alive and the children are still alive. That's complicated.
Yeah, that is. That's a really good one, actually. I'm pretty sure that it would actually be the grandchildren.
Hey, because they are, I guess, bloodline as opposed to
yeah, because it's relatives, right? Let's just go back to our trusted hierarchy just to see. So if right, so if I had a child, then it would go down to any other relative.
Okay.
And I don't actually, and so I apologize. I don't know if and I'll text my colleague if I have a moment before the end. I actually don't know if the spouse of an only child is considered a relative if the only child dies. I actually don't know.
Yeah, I appreciate that.
Yes.
Sometimes people ask me about stepchildren too. So now we're not sure about spouses of only children, stepchildren. I don't know, once we're here, if you have any thoughts on.
No, I don't have on that one either. So you guys have managed to stump me on the 2 ones, right? So I've lost all credibility in this.
Thank you. So there's another question here, Jeff, just regarding the minimum age of an SDM.
So the criteria for an SDM is that they have capacity to make the decision around the treatment or the care that's being offered. And in Ontario, we don't have an age of consent. And so the bar is whether or not the young person or the old person has the capacity to make, as the SDM, do they have the capacity to make that decision? Because, and you'll see in the cases that I've got coming up, a spouse could also be cognitively impaired. And so then, the spouse wouldn't necessarily be the automatic STM if they lack decisional capacity as well.
Thank you. So do you have time for one more?
Yeah, absolutely. Lots of
time. There's the question, can the SDM live in another country?
Absolutely. Yeah. So that one I know for certain. And so it is that they do not need to be living in Canada, and it's our job to search and track down these folks, to be honest. And so I have a couple of patients on the PCU right now whose SDMs are in the UK, and we routinely speak. So no, it does not need to be in Canada.
Excellent. Thank you for answering all those questions.
Okay, no problem. Okay, so just coming back to the kind of the framework here, I just want to get into a little bit of detail around the specifics around how this kind of works for in practical realities. So if we've got Irene H, who's recently admitted to long-term care, she's married to Alex. Her medical problems include well-controlled hypertension and arthritis. She requires some assistance with her ADLs, but no significant cognitive issues. So for Irene, or Mrs. H, we're preparing somebody who is could be considered as having a serious illness, in that she requires help for her ADLs, and I think that would put her in the categories of serious illness. So what's our role when we're preparing somebody who does have, and it really is as facilitator and educator, right? The tasks for us would be the same for a healthy person, would be to introduce the topic of advanced care planning, would be to identify who Irene's substitute decision maker is, and to then begin to prepare both her and the substitute decision maker by I think actually it's in the next bullet. Yeah. So it's exploring what they understand about Irene's sort of illness around the arthritis, offer support, information. If there is a more serious illness like dementia or like heart failure, for example, then getting into the trajectories and the kinds of decisions that are likely to happen in the future would be other tasks of advanced care planning. When could this happen? Anytime. On admission to long-term care, which I'm going to come back to. And I think most importantly, actually, would be return from a hospital visit. It's the most opportune time to, apart from cues, when a family member or patient gives us a cue around how they're feeling about their life. That's really the ideal time to have these conversations. Other than that, then I would say returning from a hospital visit is the most contextually appropriate time to be having conversations. If we think about Mr. H, Irene's husband, they have 4 children and 10 grandchildren. He has advanced COPD and dementia. So for Mr. H, we are talking more about preparing SDM for future decision-making on the bottom left. And if there aren't decisions, then it is a goals of care discussion and consent that we're talking about. So if we're preparing Irene, let's say that Irene is Mr. H's SDM, preparing Irene for future decision-making, our role really is around illness educator. So it's educating Irene about what to expect with dementia, what to expect with COPD over time, that we can expect hospitalizations, we can expect exacerbations. It would be our tasks would be to also include in that where Mr. H is on their trajectory, right? So it's one thing to talk about the trajectories of these illnesses, but it's another thing to actually point out to the person or the SDM where they are on the trajectory. Are they really early in the illness, or are they actually really quite late in the illness? And that's a really important piece of the puzzle. So it's educating Irene about the role of SDM in decision-making and consent, explore what her information needs around this might be, expectations about the role of the conversation to prepare her, and uncertainty around future healthcare needs would be kind of hone out the tasks. And also, when would we do this? Anytime on admission, perhaps, and certainly on return from when Mr. H gets back from a hospital visit. Because 6 months later, he's got new respiratory distress in the middle of the night. He's acutely confused, and we're considering transferring to hospital for assessment of his COPD or pneumonia. We're not sure what's going on. So in this case, this is when we're moving to the right side of this kind of framework, and we're having goals of care discussions we're making decisions, we're arriving at consent, we're initiating the treatment or care or not. And then we kind of go back up to the top of the equation here around this framework is really simplifying things to, are we preparing or are we deciding? Preparing can happen anytime that there's not decisions being made. Okay. Now, just in my last couple of slides here, I just wanted to point out that this kind of summarizes the outcomes of a deciding conversation. We talked about the outcomes of preparing conversation, but the outcomes of a deciding conversation would include that the patient or the SDM understands the illness, the treatment or care options, the values, what matters has been explored, and the recommendations that we're giving align with those patients' values and goals. And with this, I want to take you back to where we started out around your decision, right? You needed two information streams, two roads of information. You needed information about you had information, the image of what life would look like. You had the information around what mattered to you. And that's really what we're saying is the outcomes of deciding decision-making conversations as well. So to summarize then, did you want to jump in with a question?
We have something complicated in the chat box if you're ready for another challenge.
Absolutely, I am. Let's do it.
Yeah, okay. All right. So Julie has said, my question, if this is valid, the PGT is the SDM.
Yep.
I cannot decide for the goals of care of the resident whether a CPR or no CPR, so DNR, if a DNR is right to do, even if the doctor discussed the trajectory of the resident. The PGT has a hard time communicating with staff. Can the doctor say a final decision for the goals of care or advance directive for the resident without needing, for the resident, without needing to wait for the decision of the PGT? So basically asking if the doctor would make a decision about DNR, I think is the gist.
So I think what the question is, can the doctor give consent?
Yeah.
So what I will say is this, is for the very specific decision of whether or not to start CPR in a person whose heart has stopped, a clinician can, in that moment, make the decision to not provide that therapy, that treatment, right? So we are absolutely not obligated to provide CPR when a person's heart has stopped. Code status is tricky because it's actually the only decision that you can make about a future context, right? Because it's a decision about a treatment for when your heart stops, and you can only make that when your heart's working. So it's truly the only decision that we make about the future, right? That where there's a future context, and for that context, consent needs to come from the SDM hierarchy. So I would say that the answer is almost as complicated as the question, but if consent needs to come from an SDM, if the PG&T is the SDM, then consent must come from that person. However, in the context of a heart having stopped, a clinician is not obligated to provide CPR.
Thank you for that. And we have someone else in the chat box who says that, I guess this is based on their knowledge, that the PGT is not allowed to sign off on a DNR. So
that's not my understanding at all. Like in fact, it's their role to make decisions.
Okay, excellent. So thank you for clearing that up.
Okay.
Yeah, thank you.
Keep them coming. Keep them coming. I like that. My coffee's kicking in, so I might be overly perky, annoyingly so. Okay, so we talked a little bit about advanced care planning, conversations to prepare SDMs, where we're learning about the person's illness and prognosis, which I'll come back to, and then goals and care conversations. So I have another slide of questions. So for the 30 folks and maybe even a few more, the next question that I have for you actually is a nice segue from what we were just asked. A patient who consents, this is a true or false question. A patient who consents to a DNR code status is communicating they want their care to focus on comfort. True or false? And for those of you that want to join, on the left side of the slide, you can see joining at slido.com from your phone or from your computer. I feel like I'm at a telethon where I'm like, getting people, while people are putting in their bids, I'm like trying to jockey for them to put in more. But if you go on to slido.com and enter into the event code dining to learn, all one word, we've got 16 responses. Let's go for 20. Let's see if we can get 20. If there's 4 more people, 18, 2 more folks, 21, perfect. So almost half and half. So interesting. So half of the respondents would say that a DNR code status is communicating their care to focus on comfort, and would say no. Tara, what do you think about that?
Is communicating what they want their care to focus on. A patient who consents to DNR code status is communicating they want their care to focus on comfort. I don't know, Jeff. I guess like the terminology I tend to use is that if you choose not to be resuscitated, you're allowing for a natural death.
Yeah. And so I think what this question is really is toying with people a little bit. But it's a reminder that code status is for a very specific treatment for a very specific context, right? Code status is for when a person's heart has stopped. What do we do? Do we actually, attempt CPR? What it's often conflated with a decision to be DNR is we often assume that a person would want to, quote, focus on comfort. What's problematic about even just the phrase focus on comfort is that can mean so many different things to people, right? A focus on comfort might actually mean going to the hospital because I fractured my hip. Or starting antibiotics because I'm struggling in breathing. To some people, that wouldn't be a focus on comfort, but to others, it would. So there's a lot of subjectivity in these terms. And so I put this question up here just to sort of remind us that we have to be really precise when we're thinking about these things. So I would say that the correct answer would be false if there was a correct one.
Okay.
Right?
Yeah, and for me, like focusing on comfort means relieving suffering, but
it would be very I would be curious if a person had told me that they wanted to focus on comfort and they were a full code. That to me, so to come back to these folks that have said true, I think that's really what they're trying to say, right? Is that a person who is focusing on comfort, they should be a DNR. Yeah. If a person tells me that they're full code, then I get excited because it means that there's lots of educating that needs to be done. It means that there's lots of misunderstandings here about what we're actually talking about with any of these things. So if there's an incongruence, see that as an opportunity to educate.
Absolutely.
Okay. And our last Slido question. All right. Okay, so it might feel like a completely different left field, and we're going for 20 responses here, but true or false, more than half of patients on dialysis believe that dialysis is curing or improving their kidney disease. True or false? Half of patients on dialysis believe that dialysis is curing or improving their kidney disease. We got 13. I think 17 now. Great. Let's get up to 20, 21. So again, half and half. I wonder if it's the exact same half. We've had half and half for every question so far tonight. So I wonder if it's same groups of people. So this is absolutely true. And it's actually upwards of 2/3, closing in on 70%. It's actually true of every serious illness. A person who has metastatic cancer, 70% of them believe that the medication is going to take away all of their cancer cells. If we frame it in that way, 70% of people on dialysis believe that this machine is actually helping in curing their kidneys, helping to improve the function of their kidneys. When I first found this out 10 years ago, this is when I jumped all into this whole field around serious illness communication, because that means 70% of people on dialysis are not making informed decisions. none of their decisions are informed, right? So I was going to transition now into just a last section on informed consent and the level of care forms. So I just, if there's any questions or anything to chime in from the chat box at all.
No, I think we're good to go.
Okay. So I wanted you guys to understand just how poorly people understand their illnesses and their context and what's happening with them. And that's really why I put up that last question, is that the vast majority of people who are living with an illness that is progressive and not curable do not appreciate that it's progressive and not curable. Okay. And so each decision that person makes is not informed. And that's what brings us to this form here. So, informed consent must come from a person. Full stop. A piece of paper cannot be consent, right? So you cannot get consent in Ontario the way we're set up legally. Healthcare Consent Act tells us that consent must happen at the time that a care or treatment decision is being made, and it must come from a capable resident or their SDM. That's what consent is. Consent cannot come from a level of care form. Okay. So if a level of care form is not, advanced care planning is not, goals of care is not consent, what's problematic about it? Well, I'm hoping that throughout the examples that I've given you throughout sort of clarify that a person cannot make treatment decisions in advance, right? They're in the absence of clinical context. You cannot appreciate or know what your values, what would be important to you in the future. You just can't. We are adaptable human beings, and so what is important to me today, what matters to me today, will differ months from now, years from now. And I'm just doing a time check, Tara, just to see what time we wanted to because I realized it's 6 after 8, but I think we're going till 8:30.
I believe we are, Carl.
Okay. I'm on my last few slides anyway.
We got 25 more minutes.
Oh,
till 8:30.
We'll get people out of here early then. So just to come back to people not being able to make treatment decisions in advance. The other thing that I would say what's problematic about level of care forms is that there's such inconsistent practice as to what kinds of conversations are happening before their completion. And level of care forms are not being used in a way that could make them compliant with the Healthcare Consent Act across the province. So again, it is provocative to say that to this group, but just to reinforce, a level of care form, it rarely gets into why a treatment plan is being recommended, what are the risks and benefits, what are the alternative treatment plans. That really is what goals of care discussions are for, right? So when there is a treatment or care decision that is to be made, that's when a goals of care discussion needs to happen. That's when we're making sure that illness and treatments are understood and that what matters to the person is understood as well. Okay. So if you're thinking about practically what might differ in your long-term care setting and how could we actually move things forward a little bit. So when could we be having a resident-centered approach to these kinds of conversations? I think routinizing the conversations is always helpful if you're looking at it from an organizational perspective. I really want to come back to that notion of cues, right? If in quiet moments when a person says something like "I've had it," or they are just back from the hospital and they're talking about what it was like to be in there. Those are the golden opportunities to really explore for a person, what's important to them, what matters to them. If they were in a similar circumstance in the future, would they want to do things differently? Have they talked to their family about this? So there's going to be people on your team that have various levels of comfort with having the more nuanced and kind of depth of conversation. But if we could actually as a system recognize when a cue is actually provided, when a cue is given, and then feeling confident enough to say, would it be okay if I had our social worker come and talk to you more about this, if you don't feel comfortable to delve into it a little bit more deeply. But recognizing and acknowledging a cue. If there are some routine contexts, we've talked about this, it can be on admission. The thing about admission that's tricky, I think, is that it tends to be associated with really major life changes. Coming into an admission to a long-term care setting, it's going to be a vast amount of change likely for the person if they still do have capacity and are appreciating the surroundings. And so I wonder, it might not be the ideal time right at admission, but and so it might be something that could wait. But I also appreciate that in the middle of the night, the team needs to know whether or not 911 gets called. And I would just come back to, it's about making sure that we are available when we need to be available, and on call when we're on call, and respond when we are, as clinicians who are going to be offering treatment and care, and ensuring that we go through the proper process of consent when there are decisions to be made. So it could be then within a few months of admission, either advanced care planning or preparing the SDM. With any kind of deterioration, I've referenced this around having goals of care discussions. With any new serious illness or change in status, I think it's important to revisit these conversations. And then at the end of life, if we're preparing the resident themselves or the SDM or the family for a death in the home, these are the times to be revisiting preparing in particular. Okay. So resident-centered care is a team sport. This information is not just for physicians and nurses and nurse practitioners. It's for all team members, and I think in particular for personal support workers. To be honest, I think that personal support workers are the folks that have the most intimate connections with and vulnerable moments with people. And so I think if we're really empowering our personal support workers to acknowledge and recognize cues and give them some paths to take when a cue is made by a resident, then gosh, what a different context we would have for our residents in long-term care. I just think that would be if I could change one thing, it would be that personal support workers feel confident in recognizing cues and acting on them. That would be the one thing I would support. The other thing is that really goals of care discussions are often a series of conversations over time. It's more about just the final decision and consent. It really is. I think of consent as separate from goals of care discussion, and goals of care discussion is the process of arriving at a decision, and really, really focusing on who this person is. And that actually is my last slide. So if there are any leftover questions or comments, I'm very, very happy to take them.
We have some things popping up here, Jeff. So let me just take a peek. So what about when values conflict? For instance, a resident who cares about living longer, they want to make it to 90, but also want to be able to do their crossword puzzles. These values might conflict with medical decisions. How do people sort it out when values conflict?
So the way that I think about it is that you can have conflicting values. You can simultaneously value quality and quantity of life, because those, I think, can be often in conflict, right? I can simultaneously, when it comes to a specific decision, I am going to have to prioritize what I value. And the only way that I can do that, though, and this is what's critical, the only way that I can prioritize my values is if I understand what the future looks like, to the extent that I could understand what it looks like. If I have an image of what life can look like, then I can prioritize my values, just like each of you did when it came down to deciding very quickly about a medication or surgery, right? What you did was prioritize your values. You actually do have competing and contradictory values. We all have them all the time. But in a moment, how you prioritize prioritization can only happen if you really do have a good, clear understanding of what to expect.
Yeah, that makes sense, right? It doesn't mean it's easy, but
No.
you take the time and see what emerges, what really comes to
And again, I come back. 30 of you came to a decision like that, right?
Mm-hmm.
And the reason you could is because you have an image of what these words and what these things look like. You know what goes into 30% reduction in cognition, what that actually concretely means for a person. Because you have that, because we're part of the elite people that understand this information, then we can access decisions and make decisions in a very efficient and way. And that's really our duty to create those same conditions for everyone.
Yeah, it really does drive home that point, right? To have meaningful conversations, checking in with people to make sure they understand. Yeah, they understand the information that they're receiving. Thank you, Jeff. There's nothing else in the chat box for the time being. One more as a pop. Okay, now there are. So we have a question. Who on the long-term care team should be having advanced care planning conversations?
Oh gosh, I wish we could open that up to everyone, because I would turn that right back around and I would say to the person who's asking, you tell me who should be having these conversations. I think if we think about preparing, preparing a person and preparing their substitute decision making, their substitute decision maker, it's every person on the team. We all have a responsibility to prepare whenever it makes sense to prepare. And it might be at the, returning from a hospitalization. It might be in a quiet moment on a Friday night, Friday evening when we're sitting there just having a chat. It might be during a team, a scheduled routine meeting. So, you can decide, your team can decide how you want to approach this. Your team can decide whether or not you do want to have a routine process in place, and who feels comfortable actually taking that on. And then for the moments when these conversations sort of happen organically, what then to do with that information and who to go with. So I think it really does, there isn't a one size fits all for this. It really does come down to what you and your team decide is doable, is practical, is manageable, is meaningful, and then do it.
Thank you. There's a question. Can you give us any additional cues for discussing goals of care? When I have goals of care conversations, I try to reassure the resident or the SDM that these are fluid and can change.
So I would come back to what we were talking about. Goals of care conversations apply when there's a decision, right? So if we think, again, going back to preparing or deciding, if it's deciding, that's when we're having goals of care discussions. A goals of care discussion does not equal code status, right? Goals of care discussion is the process to arrive at any decision, but there's a decision that needs to be made, that is to be made. Otherwise, we're preparing. Right? Otherwise, we're preparing. We're preparing with illness understanding. We're preparing with what to expect in the future. We're preparing with who the SDM is and what they understand their role. And so that's what I would say, is that be super clear about whether we're preparing or deciding, and the rest will actually sort of fall into place.
Perfect. We have another question. At what age is there more harm than benefit for CPR in terms of fractures and pain?
Oh, 1 year older than me is what I would say. I was going to say 1 year older than the person who asked the question, or 1 year younger than the person who asked the question. Yeah, there's, I think we have to be cautious actually around how, when we're describing CPR, to not to be honest, but not cross the line to coercive, right? Like we can frame CPR in really barbaric sort of terms, because it's kind of barbaric when it happens and it's effective. So it's a really tricky thing to talk about code status. And I think the way that I would sorry, I know it's a bit of a tangent, I'm going off on the field. There isn't a specific age, because a 16-year-old could have congenital osteoporosis and quite be debilitated or harmed quite substantially from CPR. So the answer to the question is there isn't a specific age. But what I would say is, taking from that, is for us to be mindful in how we're describing CPR. And what I would say is, little pearl or the tip that I would say is always remember not to presume that resuscitation is the outcome, right? So it's attempt. We're attempting to resuscitate. We're not resuscitating. We're attempting to resuscitate. So anytime I hear myself using the word resuscitate, I always put the word attempt ahead of it, because unless you do that, the presumption is that it will be effective, when we know very clearly the presumption needs to be that it won't be effective, actually.
Yeah, and
It's
would it be
much.
fair to provide some stats on?
Do you know some of the great things that I've seen are the images of like 100 people, and then the number of people for whom CPR was designed for, i.e., young people who all of a sudden their heart stops unexpectedly. That's who CPR was designed for. And then I think there's like 8 people that CPR works for, and then the 3 people that are in hospital, that's who it can be effective, and the 1.5 person who gets out of ICU, and the quarter person who um, um, you know gets discharged from the hospital. There's that image, I think, is really an efficient way to explain to people the effectiveness of CPR
Without being overly gruesome.
Yeah, exactly. Yeah, it's a nice way to, you know what I'm talking about, that it's for the image of
Yeah, the
100
little
people. Yeah,
shadow people. Yeah.
yeah. If you just Google that, for anybody that's listening, have Google it, and it'll pop up. It's a really um, uh, effective and efficient, for a time saver as well.
Absolutely. One more, Jeff, is that okay?
Sure. Yeah.
A comment. I'm surprised that people have so little understanding of the illness they have. What can be done to improve people's knowledge of their illnesses?
That's such a great question. Thank you for asking it. It is shocking and jarring. And what I will say is this: it doesn't mean that conversations aren't happening, but it means that we're not confirming that a person is understanding what we're saying, um, and that we're not revisiting it over time. So that's what I would say, is that to be effective, it is to ensure that we're considering health literacy, that that our language is matching the person's understanding, ability to understand, that we're confirming that they understand the information that we give them, and that in a way that's not badgering, that we revisit over time, and ensure that the understanding is maintained. It's an important thing. We have to remember that people walk away remembering sort of 1% of what we talked about, what they were told in their visits. And if it's information that's not particularly welcomed, that tends to be not remembered, or not appreciated. So it is, in my view, the number one challenge that we have as a healthcare system. And so I would really encourage, if you're in a team, or this evening, or if you're part of a team, is how's your team going to address this? Are we going to address knowledge of dementia or knowledge of frailty? Because these are common enough problems that the education could be organization wide.
Thank you, Jeff. Thanks for all of your explanations and clarifications. It's been great.
It was really enjoyable. I thank you to all that participated, and for the great questions, and thank you for the invitation. I really appreciate it.
Absolutely. Yeah, thanks so much, Jeff. And thanks everyone for participating so much and asking so many questions. Really makes it a lot more interactive. And yeah, we really appreciate you all joining us tonight.